day. I would like to thank the organizing committee for this opportunity to give this talk on the diagnosis and treatment of seizures in the acute and emergency setting. Seizures represent a frequent challenge encountered in the emergency department. Whether presenting with an isolated or unprovoked seizure or with status epilepticus, a good understanding of seizures and their mimics, coupled with an accurate history and directed physical and neurological examination, ensures appropriate investigation and treatment. I am Dada Mesina-Nepomuceno, a neurologist, and my talk today will focus on the practical aspects of the management of patients presenting with seizures to the emergency department. I have no disclosures with regard to this topic. In general, our objective is to apply appropriate diagnostic and treatment strategies for a patient who presents with seizures in the emergency setting. Specifically, at the end of the lecture, the viewers are expected to differentiate between seizures and seizure-like events, evaluate a patient who presents with seizures in the emergency setting, and formulate a treatment plan for a patient with seizures in the emergency setting, including status epilepticus. So we will go from recognition to evaluation and then treatment. A few terms that we have to define. We have to differentiate between seizures and epilepsy. So seizures is a transient occurrence of signs and/or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain, while epilepsy is a disease of the brain defined by any of the following conditions. So first, at least 2 unprovoked or reflex seizures occurring more than 24 hours apart. Second, 1 unprovoked or reflex seizure and a probability of further seizures similar to the general recurrence risk of at least 60% after 2 unprovoked seizures occurring over the next 10 years. And lastly, a diagnosis of an epilepsy syndrome. Epilepsy is considered to be resolved for individuals who had an age-dependent epilepsy syndrome but are now past the applicable age, or those who have remained seizure-free for at least 10 years with no anti-seizure medicines for the last 5 years. And we also have to differentiate between provoked versus unprovoked seizures. Provoked seizures include your acute symptomatic seizures, and it's defined as equivalent to an acute symptomatic seizure or a seizure that occurs at the time of or within 7 days of an acute neurologic, systemic, or metabolic or toxic insult. So examples would include seizures resulting from metabolic derangement such as hyponatremia or other electrolyte abnormalities, withdrawal syndromes, toxic ingestions, encephalitis, CNS mass lesions, and many others. While unprovoked seizures include your remote symptomatic seizures. They occur without acute precipitating factors and include but are not limited to remote symptomatic seizures if the seizure is thought to result from a CNS or systemic insult that occurred more than 7 days in the past. This would include your idiopathic seizures, epilepsy, seizures attributed to a history of stroke, traumatic brain injury, or other past events. This is the latest seizure classification from the instruction manual from the International League Against Epilepsy in 2017, wherein they operationally defined the classification of seizure types. So our partial seizures are now replaced by the term focal, and this can be further qualified whether the awareness is retained or not, so that your complex partial seizures now become your focal unaware seizures, and your simple partial seizures in the past now becomes focal aware seizures. Previously termed as secondarily generalized seizures is now replaced by focal to bilateral tonic-clonic seizures. First, generalized onset seizures, they can be described as generalized motor, which would include your tonic-clonic seizures, or generalized non-motor, which refers to your absence seizures. Unknown onset and unclassified seizures or classification has been added, acknowledging that not uncommonly, seizure onset and etiology cannot be defined. So, seizures are a common presentation in the emergency room, accounting for about 1 to 2% of all emergency department visits. They affect more than 3 million people in the United States. Of these, more than 200,000 new cases are seen, and about 40 to 50% will recur and become epilepsy. Of these, 100,000 will be in status epilepticus. They affect all ages, but incidence is highest in the extremes of age, those younger than 2 years old and older than 65 years old. There is a slight male preponderance in epilepsies. So in recognizing and evaluating seizures in the emergency room, we have to take note of we have to take note of 4 key questions to guide us in our management. So the first question would be, is the patient presenting with a true seizure or a seizure mimic? Second, are there any underlying causes or is it secondary to a seizure disorder? Third, is this a first-time seizure or does the patient have an established seizure history? And lastly, is the patient in status epilepticus? So, depending on which part of the brain the seizure originates from, presentation will vary from the typical focal motor seizures or those that we know as aversive seizures, wherein the patient will have a preferential gaze to one side, to ones that are less straightforward, as in focal seizures presenting as visual or auditory hallucinations, psychomotor phenomenon, impaired consciousness, and the like. A thorough history, including a witnessed account, will allow the diagnosis to be made in the majority of patients. If our patient is unconscious, we can interview family, friends, companion, caretakers, or any pre-hospital personnel. Often, a history of epilepsy is noted in these patients, so they may be having breakthrough seizures. Other history findings that may be elicited are the following. So in patients with known history of epilepsy, there may be a recent non-compliance with medications. You can also elicit a history of central nervous system pathology, particularly stroke, neoplasms, and recent head surgeries. History of systemic neoplasms, such as metastatic brain lesions, may be seen in these patients. Also, infections, metabolic disorders, and toxic ingestions. A recent history of trauma or fall, alcohol abuse, recent travel is important. Especially in women, we note a history of pregnancy or the postpartum state. We also look for focal symptoms, which will pertain to partial seizure activity that then progress to a generalized seizure. So these are the things that we'll be looking at in terms of the history of our patient. So in particular, seizures in known epilepsy patients, these are the things that we will be asking because this is an extremely common scenario. We ask about the usual pattern of the seizures, frequency, as well as when the last attack was. So this is very important when we are interviewing our patients. Patients can present reporting deterioration in their usual frequency for a range of reasons, including perceived changes by the family or the patient, wherein anxiety ensues, intercurrent infections or systemic illnesses, alcohol and recreational drug use. It can be medication-related also, such as poor adherence or compliance to medications, certain changes in the formulation we commonly encounter in the clinics. Also, during planned withdrawal or changes to medications, we can have breakthrough seizures. Drug interactions with other prescribed medications, as well as over-the-counter medications. And of course, there can be an acute symptomatic seizure, for example, due to a recent head injury. So the history is key. A variety of clinical conditions may lead to events that resemble convulsive seizures, but are in fact, they're not. Examples would include the brief stiffening or rhythmic jerks that sometimes accompany syncope or concussion, rigors, psychogenic non-epileptic seizures, and many other clinical conditions. Even after a thorough evaluation in the emergency department, being able to categorize a clinical event as a seizure may be difficult. So, an example would be transient loss of consciousness, which is a common complaint that may present to many different specialties under various labels, including blackouts, seizure, blank spells, and falls. The term transient loss of consciousness itself is non-specific and includes all causes of self-limited loss of consciousness regardless of mechanism. And the most common cause would be syncope, followed by epileptic seizures and non-epileptic seizures. A thorough history, including a witness account, again, we can never emphasize the importance of a thorough history because it will allow a diagnosis to be made in the majority of patients. So distinguishing seizures from syncope and functional non-epileptic seizures can be difficult, but these are equally important diagnoses to make so that we will not be exposing our patients with non-epileptic seizures or syncope to inappropriate interventions and treatment with anti-epileptic drugs. So in our investigation, what is suggestive of a seizure would be the slow return to the baseline mental status or from the post-ictal state, a witness account of shaking or tonic-clonic event, and bladder and bowel incontinence. While what is more suggestive of syncope is the rapid return to baseline mental status as opposed to the slow return in seizure. And of course, EKG changes such as dysrhythmias or long QT syndrome. So this is the Sheldon questionnaire, which is a useful tool in differentiating seizures from syncope. So you have several questions listed. Depending on the question, you have designated points. So if the patient answers yes to a question, he or she is given the corresponding point score. A cutoff score of less than 0 classifies the patient as having seizures with an overall accuracy of 86%, sensitivity of 96%, and specificity of 84%. So this can be a useful tool in the emergency setting. Needless to say, we will be performing a directed and focused physical and neurological examination. There will be times that you will not be able to complete the whole of the neurologic examination. So we will be focusing on the important deficits that we will be looking for. So first is we look for signs of possible seizure etiologies. So low-grade fever may present initially, but prolonged fever may be an indication of an infectious etiology. We also note any changes in the mental status examination for our patients. Focal deficits on neurologic examination may be evidence of an old lesion or a new pathology, or Todd's paralysis, wherein there is a unilateral hemiparesis or hemiplegia that is transient but lasts less than 24 hours. And of course, this can mimic a stroke. We also find that hyperreflexia and the extensor plantar responses may indicate a recent seizure, but they should resolve during the post-ictal period already. So the following are the differential diagnoses to seizures. They range from various neurologic conditions such as stroke, movement disorders, dementia, CNS infections, where they also present with seizures. You also have non-neurologic conditions, including eclampsia, arrhythmias, and psychiatric conditions such as fugue states, malingering, and psychogenic non-epileptic seizures. Among our patients who presents with seizures in the emergency room, most of them will be needing a neuroimaging study. So who will need the study immediately? So MRI is of course the imaging modality of choice. Usually we request it with a seizure protocol. A CT scan would suffice in the absence of an MRI. So patients with acute head trauma, new onset focal neurologic deficits, altered mental status, recurrent seizure or recurrent events, persistent headache, those with history of anticoagulation or immunodeficiency or malignancies, fever, those who have focal seizures, as well as new neurologic symptoms prior to the seizure, will warrant immediate neuroimaging. And of course, those in whom we cannot ensure follow-up, we will need to do an imaging study of the brain immediately. What about laboratory and other investigations? So, of course, part of our evaluation would be requesting for hematologic and biochemical workup for metabolic derangements that may cause your seizures. Electrolytes, your blood gas, your renal function tests, your liver function tests, etc. Tests that will evaluate for infections such as your blood count, blood cultures, and other microbiologic studies, as well as assays for drug levels and toxicology studies. An electrocardiogram is also requested to rule out arrhythmias, which may present like a seizure or may be a seizure mimic. An electroencephalogram, especially for a first ever seizure, is also requested. However, they are rarely required in the emergency setting. So these can be requested once the patient is already stabilized and admitted at the wards. A lumbar puncture and CSF analysis is also requested in patients in whom we suspect to have CNS infections. And of course, pregnancy tests can also be requested for patients suspected to be pregnant and in the reproductive age group. Treatment is basically supportive for patients who present with seizures in the emergency room. The ABCs, your airway, breathing, and circulation, should be evaluated as necessary, including oxygenation and airway assessment, temperature assessment, blood glucose, and spinal precautions. And of course, your IV access must be secured so that we'll be able to administer our medications right away. So while treatment is initially mostly supportive, in caring for the seizure patient in the emergency room, the following are major considerations. So there are three basic pitfalls that must be avoided. So first, we must recognize seizure activity. So our seizures may present typically or atypically, and these must be properly evaluated in the emergency room. Your non-convulsive seizure is a rare presentation of altered mental status, but should always be on the differential in a comatose patient. And in these patients, your EEG is a diagnostic modality of choice to identify these patients. The second failure or pitfall is to control seizure activity aggressively. Neurologic dysfunction is theorized to occur after 20 to 30 minutes of continuous seizure activity, even despite adequate oxygenation and ventilation. Therefore, there should be a low threshold for aggressive treatment of any seizure activity that lasts over 5 minutes. As neurologic dysfunction can happen after 20 to 30 minutes of continuous seizing, and status epilepticus now becomes more difficult to control. The third one is the failure to consider the underlying etiology. So, although medication non-compliance and subtherapeutic medication levels are among the most common causes for seizure presentations in the emergency department, patients should be screened for underlying causes such as infections, metabolic derangements, and the like. In patients with therapeutic medication levels, fever, and other indications must be considered in requesting for your laboratory and imaging studies. And breakthrough seizures, we must remember, may occur even if our patients are compliant to their medications. So remember these. We must recognize seizure activity, control seizures aggressively, and consider the underlying etiology. So this diagram outlines the treatment algorithm for patients who presents with a possible seizure in the emergency room. So if a patient comes into the emergency room with possible signs and symptoms of a seizure, we evaluate them right away. So we get our history, we do our physical and neurologic examination, and we perform our diagnostic laboratory examinations, including your hematologic exams, and your brain imaging studies, and an EEG if warranted. So if your diagnosis could be epilepsy or a seizure, you will further classify whether it's a first seizure or a second seizure. So if it's a first ever seizure, we must look at the risk for a second seizure, because if the risk is low for a second seizure, then we must treatment is usually not started immediately, and the individual risks and benefits of treatment with anti-seizure medications must first be reviewed and discussed. While if the patient is high risk for a second seizure, or is already on the second seizure and or beyond that, then the patient is already diagnosed to have epilepsy, and should begin treatment with anti-seizure medications. While if your diagnosis is not likely epilepsy or not likely a seizure, and may be secondary to a medical or a psychological or psychiatric cause, then these patients should be evaluated further to ascertain the underlying etiology and will be treated accordingly. According to the National Institute for Health and Care Excellence, or the NICE guidance, anyone with a suspected first seizure should be referred to a specialist for assessment and should be seen within 2 weeks. Most patients with a single self-terminating seizure who have made full recovery can be managed as outpatients through a local first seizure pathway where they are worked up. Like what was mentioned earlier, anti-seizure medications are not indicated in first ever seizures unless they are high risk for recurrence. So how do we determine if a patient with a first ever seizure has a high risk for recurrence or for a second seizure? So in adults, assessment should include checking for the following modifiable risk factors, which may increase the risk for a second seizure. So the first would be an underlying mental health problem, such as depression, anxiety, psychosis, and alcohol or substance abuse or misuse. Certain vascular risk factors may also predispose a patient to be high risk for recurrence after a first ever seizure. So stroke, diabetes, hypertension, and atrial fibrillation. And lastly, those who have had sepsis. We should develop an individualized anti-seizure medication treatment strategy with our patients and their families and caregivers, taking into consideration the following. So the patient's age, the patient's sex or gender, the patient's seizure type or epilepsy syndrome, whether treatment is needed or not, as in the case of your first ever seizure, as well as the risk and benefits of anti-seizure medications, including their importance in reducing the risk of epilepsy-related deaths, any comorbidities that the patient would have, and possible interactions with medications that the patient is already taking. Personal preferences, as well as the preferences of the family and the caregivers are also considered here. As well as personal circumstances such as education, employment, likelihood of pregnancy in patients within the reproductive age group, driving, alcohol use, and traveling, as well as the cost of the medications. Also, we have to take into consideration how and when anti-seizure medicines are to be taken so as not to lose the patient due to non-compliance. This table just lists down the different doses and routes of administration strategies in patients with presenting with seizures in the emergency room when you are resuming anti-epileptic medications in these patients. So lastly, we talk about status epilepticus. So we all know that it is a medical emergency. It was previously defined as 2 or more sequential seizures without full recovery of consciousness between the 2 events, or more than 30 minutes of continuous seizure activity. So at present, it is defined by 2 time points. The first time point is when a seizure has failed to self-terminate and has become abnormally prolonged. So that is usually more than 5 minutes. The second time point is when there is a risk of neurological damage and long-term consequences. If the seizure is prolonged, there is already the risk of morbidity and mortality if not controlled by 30 minutes, especially in cases of, later on we'll see, convulsive status epilepticus. So status epilepticus may be convulsive, wherein you have a patient who demonstrates tonic-clonic seizures that is persisting or recurring without recovery beyond 5 minutes. And it can also be non-convulsive, which is more difficult to assess because a diagnosis is usually based on the EEG findings, but will present as decreased sensorium. So how do we treat status epilepticus? So this is a protocol that is based on the Philippine League Against Epilepsy guideline, which has been adapted to what is currently available in our local setting. So when a patient arrives at the emergency room actively seizing, we should stabilize the patient, secure our ABCs, we hook the patient to oxygen, obtain our vital signs, perform a brief history and physical examination, and observe for any neurologic deficits. Within 5 minutes, we must already be administering our benzodiazepines, so midazolam 5 milligrams IM, or diazepam 5 milligrams IV, once IV access has been secured. We may give our IV diazepam as needed for seizure recurrence up to 20 milligrams per day. So the maximum would be 20 milligrams. And then we refer to our colleagues in neurology. So after which, so during the interim, we obtain our blood work. So you obtain a blood gas, your glucose levels, your blood chemistries, CBC, your electrolytes, and your drug levels, your serum, anti-seizure medication levels if necessary. You may give 100 milligrams of thiamine via intravenously or intramuscularly. After 15 minutes, if your patient is still seizing, we can load our patient with IV valproic acid, 40 milligrams per kilogram, infused over 5 to 10 minutes, or IV levetiracetam at a dose of 60 milligram per kilo, infused over 5 to 10 minutes. If our patient is no longer seizing within 15 minutes, you can already admit your patient to the ICU, start your IV maintenance anti-seizure medication, and do your workup for your underlying etiology. If within 30 minutes, our patient is still seizing, so after 15 minutes of giving your IV valproic and IV levetiracetam, the patient is still seizing, then we can load either IV levetiracetam if you started with valproic acid, or IV lacosamide at a dose of 200 to 400 milligrams over 3 to 5 minutes. We now consider here intubation and midazolam drip. If our patient is still seizing after 15 to 30 minutes, then we intubate our patient already so that we will be able to start our midazolam drip. Okay, we load at a dose of 0.2 milligram per kilo with an initial rate of 0.1 milligram per kilo per hour, and we can titrate this up to 2 milligram per kilo per hour. And then we facilitate the admission to the ICU and hook the patient to the mechanical ventilator, and continue our maintenance AEDs. If continuous EEG monitoring is feasible, then we can have this done to our patient. And of course, work up our patient for underlying etiologies. If after giving your midazolam drip, your patient is still seizing, then we maintain assisted ventilation and consider anesthesia referral already, because if your patient is still seizing after your midazolam drip, then anesthetic agents are already warranted, such as your propofol, thiopental, pentobarbital, and ketamine. Institutions with emergency medicine programs, as well as internal medicine programs, should have a status epilepticus protocol such as this. And this is just a list of the IV medication options if generalized convulsive status epilepticus continues after the initial benzodiazepine administration. So unfortunately, I think IV phenytoin is no longer available locally. That is why the Philippine League Against Epilepsy revised the recommended status epilepticus protocol to include available medications. So that is the last slide. In summary, seizures and seizure mimics are common presentations to emergency departments and acute medical units. History, including a witnessed account where possible, is key, aided by the rational use of different diagnostic modalities to be able to treat our patient appropriately. Seizures may be provoked or unprovoked, and identifying the underlying cause has implications for treatment and onward referral. And lastly, status epilepticus is a medical emergency, and appropriate timely treatment should be delivered for the best possible outcomes. Thank you very much for your kind attention, and I will be glad to answer your questions later in the open forum.